Hi, and welcome to our session today. We're going to be talking about communication and language, and with regards to its significance for young people with complex emotional needs associated with the diagnosis of personality disorder. This is all taking place as part of A Tale of Three Cities Goes Global 2022, which is a series of events throughout May across Manchester, Birmingham, London and beyond, reaching digitally. The events take place during International Borderline Personality Disorder Awareness Month, and they aim to explore and bring change for young people with needs associated with the diagnosis of personality disorder. My name's Maddi, and today I'm joined by Peter Fonagy and Carla Sharp. In a minute, I'm going to ask them both to introduce themselves, but first I thought I'd tell you a little bit about myself. So as I said, I'm Maddi Crease. I work for the Anna Freud Centre for Children and Families, and I work in the field of participation. This means that I work in lived experience. I'm a lived experience practitioner, and I mainly work to train professionals and also develop new projects, but I sometimes work on events such as ones like this. And I always use my lived experience within my work, so maybe some things like that will come up today, just a small warning there. For Tale of Three Cities, we've also shared a video earlier on early intervention and prevention, and we'll be hosting a creative event for young people to share artwork and poetry based at the Anna Freud Centre in London. Now, if I could ask you, Carla, to please introduce yourself and maybe tell me a little bit about your work.
Sure. Well, thank you, Maddi, for inviting me to do this conversation with you and Peter. It's a real pleasure to be here. I am a professor of clinical psychology at the University of Huston in Texas, in the United States. I did have a stint in the UK. I'm originally South African, but I did spend about 8 years in the UK when I was doing my PhD and my postdoc. I came to the United States about 2004. I've always been interested in the concept of theory of mind or mentalization. And it was actually Peter who introduced me to working with people with personality disorder. And I really pivoted towards developmental work in young people with personality challenges during the time that both Peter and I were working at the Menninger Clinic. And we were engaged in a large research project where it turned out that about a third of the young people met criteria for personality disorder. And so I learned a lot about personality challenges there and have been studying personality development in young people over the last 10 years. And more recently, looking at how best to support families in addressing personality development and scaffolding personality development in young people. And that's really my background.
Thank you, Carla. And Peter, if I could ask you to do the same, please.
Yes, so my name is Peter Fonagy, and I am also by profession a clinical psychologist, but I am a chief executive of the Anna Freud Centre, and also I work at University College London as a head of division Psychology and Language Sciences. But basically what I do, what I'm interested in is call them personality disorders, call them complex emotional needs, call them by whatever name, people who have, who experience really deep distress in relation to where they are, the world they are in, at an early stage in their life, and in adolescence, when really people should be finding new ways of being in the world, and actually they are in a very often in a very difficult place. How we can help them, how we can support them is really what I would like to do. And like Carla, I've committed my professional career to it. Let's hope that this will make a small contribution to that rather grand day. So, Maddi, thanks for inviting me.
Thank you both. So our topic today is communication and language, which is something that I myself am really passionate about as well. And that's both in work and outside of work. I'm a poet and artist, and I often work on mental health themes, meaning that basically when I'm working on my art or my poetry, all I have in mind is communicating ideas, especially around mental health, that can be very raw to receive and to offer as an artist as well, and communicating them in a safe way. So actually I see a lot of parallels, interestingly, between that and mental health, which is why I'm really interested in this event that's coming up in May. But I digress, and I think we should ask our first question, which is, I think it's really important to understand just why language and communication is really important when we talk to young people or their families about mental health. And so I wondered if you could tell me what good communication and language means to you and its significance to you. Carla, would you like to start?
Sure. So I was very happy to see the questions that you listed for this conversation this morning, because I think language and communication is absolutely critical for the work that we do. And it is because many of the young people, by the time they come to us for help for their mental health problems, they have several years behind them of feeling very misunderstood. Mm. And it's not only the teens who feel misunderstood, but it is also their families. And there's an internal level of misunderstanding. So young people feel they're misunderstood by their parents. Parents feel that they're misunderstood by their young person. Most parents have what we always talk about in my clinic as their deep objective is to have a healthy and a happy child. The young person doesn't see it from that perspective. The young person often experiences demands being placed on them to be reaching certain milestones or to be growing up, and they're doing it too slowly, or they're causing trouble for their parents. So there's a real sort of sense of misunderstanding between parents and their kids. But there's also a feeling of misunderstood by the wider world. By the time we see young people and their families, they have been misunderstood by clinicians. They are often misunderstood by society. Parents feel stigmatized because their kids have mental health problems. Young people feel stigmatized themselves because they have mental health problems. And they sometimes struggle with issues that are misunderstood even at a broader level, gender identity issues that they're busy. And this is the task of adolescence, is figuring out your identity. But superimposed on a wider socio-political context, this can get very, very complicated. And so I think communication and language is critical, because you're basically entering a situation, I think, of great misunderstanding, and we have to really slow down and make sure we communicate very, very clearly and communicate with open ears, so that we can begin to disentangle the levels and levels of misunderstanding that have occurred by the time young people get to us.
Thank you. And how about you, Peter?
I agree with everything that Carla said. I would perhaps add that being misunderstood is an incredibly painful experience. And it's not simply an issue of the absence of understanding. It's something much deeper than that. It's a feeling of loneliness, isolation. It's not a place where you want to be, feeling misunderstood. And that applies all around, as Carla pointed out. I think I would say that the way that I look at the problem that we are talking about today, communication, language, but also how one understands one's own experience and how one understands what other people's experience might be, is at the very core, is at the heart. So that misunderstanding is not occurring by chance. It's really something that we need to tackle if we're going to tackle the problem.
Thank you. And I have to say that I completely agree. I mean, I've been in situations as a patient before I was in this field of work at all, where I have been sat in rooms, you know, thinking nobody in this room is hearing me, nobody in this room is seeing me, and I don't know how to change that. And for me, I think that communication and language from a professional perspective is about not giving the tools even, but kind of suggesting some of the tools, seeing how they feel, suggesting what could work, seeing what works for the young person, and really collaboratively kind of creating a universal understanding between the people in that room and in that situation about what is wanted, what is needed, and what the next steps could be. And that will lead me on to our next question, which I suppose is quite a broad question. It's quite difficult to answer because every single person is, of course, different. But I'm going to ask it anyway. And I'm going to ask what good communication and language would look like in your eyes, with a consideration on personalised care, accessible and sympathetic language, things like that. And perhaps this time we could start with you, Peter.
Okay, thanks for that. It's, as you said, not a straightforward question, but let me say how I do it. Okay, so this may not be the right way, but this is what I do. So the big realization for me, the big recognition for me was that humility is where it has to start. That you actually have to accept that you don't understand, that you don't know. And you start by validating the perspective of the person that you're talking to. So you say, look, what I'm understanding from this is, and then you validate. And you make sure that they know, you may not understand why or how, but you're willing to learn about it, and you're willing to know more, and that you're curious, and you genuinely want to understand. And the word that's there, that's important, is the word genuine. That it's a genuine wish to actually respect, recognize, and want to understand what and ultimately why. So what is it that that person is feeling, and what is it in the world that makes them feel that in their eyes? And once I feel that I'm looking in the same direction that they are looking, I'm seeing what they are seeing, then I think I've earned the credit, or whatever it is. We have a platform for communication. Until then, I have no right to say anything. I have no right to impose my perspective, because I haven't shown that I actually understood the person I'm communicating with. And that's when I feel clinicians often do it wrong, because they're too keen to say, oh yes, but you say that, but the way I see it is this. And that is missing a trick, is missing a step. Okay, what is it that I'm looking at? Let me fully understand. What is it that you're telling me? So communication and language has to start, as you put it, how it looks like in your eyes, as what it looks like to you. That's my perspective.
Thank you, Peter. Carla, what do you think?
Well, I think Peter absolutely hit the high notes. I think if I can elaborate a little bit on why it may be that therapists use unhelpful language or use unhelpful communication strategies that end up in the sort of context of mentalization-based approach, closing the door for learning, right? So the moment the therapist begins to engage, or the parent for that matter, begins to engage in, or the teacher or the school, begin to engage in communication that is experienced as unhelpful, that door to learning in the therapy context, or in the school context, or in a home context, begin to close. Peter has talked about the epistemic highway, the learning highway, the knowledge highway begins to close. And I think, it's helpful to sort of pause for a moment. Why would therapists or people often in authority positions, where there's a power differential, between a parent and a young person, between a therapist and a client, between a teacher and a young person, there is a power differential. Why does it happen that these people are not using helpful communication and language? And in my experience, it is often because they feel anxious themselves. They're presented with an issue, a young person who's self-harming, a young person who's beginning to want to drop out of school. These are high stakes situations where a lot of grown-ups feel very anxious. And they jump into what we call teleological mode. They want to fix things. And that comes from a good place. The problem is that then shuts that door to the learning highway, and it erodes trust. The young person does not feel that this is a safe environment. They don't feel understood. All the things that Peter talked about, that's important, to slow down, to create that space where we can find, and I like the way you put it, Maddi, too, that it is a collaborative. It's a collaborative process of finding a joint understanding of what is going on. That's what then goes out the door. And we see young people, therapists hopping for that reason. They try a therapist out for 2 or 3 sessions, and then they give up because they don't find that space where they can feel understood. I really appreciated Peter's emphasis on humility and genuineness. The other word that I've been talking or using a lot is authenticity. I think adolescents in particular have an authenticity radar. They sniff you out very, very quickly. What does it mean to be authentic? And this is something that DBT also teaches us. I think Marsha Linehan made that contribution as well in terms of bringing authenticity to the therapy room. But it is putting your mind on the table, being able to say, well, this is what's in my mind. I don't know how that matches with what's in your mind. Can we talk about that? Because by doing that, you're not pretending to know something or pretending to be something. You are honestly expressing your misunderstanding and sometimes even confusion about what is being presented. And I think that is how the authenticity can enter into the serve and return between you and the other person that you are busy talking with.
Thank you. That's really interesting additions. So as a participation professional, I'm always an advocate of asking young people and taking on board their responses and doing that really carefully. And that's even if they may not align with the way you would usually work, which I think we've touched on a little bit so far, saying about meeting people and listening and understanding, and then taking the time to say, right now, I think I get it. Where do we go from that point? And I'm not saying that it necessarily means that you change everything you do. It doesn't mean that you go into your therapy room and you do every single thing the way that perhaps it's initially wanted. But it certainly means that you put in some consideration as to where you're going to meet them, where they're going to meet you, how this is going to help you both form a relationship and form a therapeutic pathway. And so, again, I don't want to generalize, but I wonder if you could tell me about any things that you would typically hear from young people about how they like to communicate, what good things work for them, just any tips you might have. Carla, maybe if you could start.
Mm-hmm. It's a very good question, and I think probably with young people in the context of clinical therapy work, and it's a concept in mentalization-based approaches to name the elephant in the room. I think young people, and it helps with authenticity too, because most young people come to you under duress. They do not, someone brought them there. They do not have, independence to decide where they're going for help or who they're going for help or what the process is going to be. If it's an inpatient setting, it's even more under duress than what it is in other circumstances. So I think from what I hear from adolescents is they really appreciate it when we take some time, and probably the first session, to just talk about, you know, the elephant in the room, which is you don't want to be here. And you're talking to a strange lady, and you don't necessarily want to talk to her. So I think that's one of the first things. And some young people do want to be there. So don't you know, I don't want to create the impression that all young people don't want this, but they feel legitimately distrustful of the process. And naming that elephant in the room, I think, is one of the first things that are important to do. I also think not to rush things. I think young people feel very rushed. And I think it's coming back to this idea of fixing things, or the teleological mode. You know, they feel that people are not taking their time with them. And so the therapist needs to resist the impulse to want to rush things. I think, unfortunately, in mental health, we also, the mental health system is rushed. We're in a place where we think we need to do things in 6 and 12 sessions, and we have to stick with a manual, and we have to sort of move things forward in a timely manner, you know, and we only get insurance for 6 sessions or 12 sessions. So I think the whole context is rushed, and I don't think adolescents respond well to being rushed. So I think that what I hear from teens is, don't rush me. Let's slow down. Let's take the time to really, you know, put the magnifying glass on what's going on, like Peter described earlier. So I think two tips. You asked for tips. You know, I think name the elephant in the room, if there is an elephant in the room, that they don't want to be there, and don't rush. There's, you know, it's almost, we have to almost suspend time, I think, when we're working with young people.
Thank you. And Peter, what would you say as well?
I again totally agree with Carla. These are two of the most important things, probably. I often wouldn't expect necessarily to hear from them before I talked about myself a little bit. So putting my experience and my history and what brought me there on the table and start a conversation. I stopped talking about clients, patients, using and I talk about conversational partners. So I have a conversational partner, you know, so I have to show genuine interest in what they have to say. I wish to, you know, elaborate what they are saying is best my understanding of the communication is, but also to contribute to it from my own experience. And and sometimes I think one tip that I would have is reach into your own adolescence. Try and remember what you experienced. And it's not necessarily generalizing from that and say, well, you must have experienced the same thing, but saying, but you felt this, but I remember feeling that. I wonder what the difference is between the two of our, you know, my experience and yours. Is then, you know, so it's to try and not assume that just because something was said to me, I actually understood it in the way that it was intended. So, you know, when somebody says, I feel sad, that's not enough. You know, just understand, what is it that, you know, because I remember feeling sad, and when I felt sad, you know, I just would shut myself in the room and would just not do anything. And I just can't even remember what I did, but I would just, time would just disappear. But what does it mean for you when you feel sad? And try, as I said, to make as few assumptions about what I hear as possible, and to have as clear a picture as I can.
Thank you. It's almost like you've read my mind there, because one of the next things I was going to say is, how can we be aware of our own experiences and how they influence our communication? So one of the examples for me is I used to work on inpatient mental health wards as a peer support worker. And I found that I was more susceptible to my own influence than I thought I was going to be walking in. I definitely went in with an idea of what others might be feeling or thinking or experiencing based on what I had experienced in my lived experience of mental health wards. And that kind of gave me a little bit of help. It gave me a rough guide of what I might be able to expect, some of the things that I would need to prepare myself to see, some of the things that might not be so significant. But actually, when you get into a setting, that's the setup, and then you have to adapt yourself pretty quickly to the reality. So you can hear from people based on what they're saying and not what you're thinking. And that can be some things really small, like, I don't know, maybe I think the environment's a really nice environment on this particular ward and they think it's awful. Or it could be something that's a lot bigger, for example, their opinion on how they're being treated by a particular staff member, and they may feel extremely dismissed and you might see something slightly differently. But it helps me to remember that despite my experiences in mental health, this is my working day, but it's someone else's life. They do not step back from that life at the end of the day, and I do. To an extent, of course, but I do. And that means I can have my thoughts, but for me, it's always my job to uplift an individual's thoughts about themselves rather than tell them what I think they're thinking. And so I wonder if you could discuss as well how we can be aware of our own influences and how useful it is to consider these. Peter, I wonder if you want to start, since you kind of led me into that one.
Well, I'm very glad that I did, because I think this is probably the key question. Because what I think young people who have present with these problems experience is a vulnerability to exactly that situation, but they're insufficiently clear about, insufficiently coherent in their own view of their own thoughts and feelings, that they're vulnerable to somebody telling them that that's what they're feeling. And that's how you destroy them. That's really the thing that you mustn't do. And that's why in my approach, really, it's really cherishing and nourishing the kind of evolving perspective a young person has of themselves, and try and minimally influence it, if you like. Even if it's something that I say I really wouldn't go there. I think that's a terrible place that you're going. But actually, maybe yes, maybe no. I'm not so sure. But what I know is important is that that person should develop a sense of themselves, and that I am there really to make as few assumptions as possible, and to be as open as I can be about myself, but also as open as I can be to the possibilities that our conversation might create, and to have an attitude of not what we call a not knowing stance. I don't know, but I'm really, really, really keen to find out. And I think you have to, at that point, really put yourself a little bit in the background, out of respect for the other person and the other individual. And if you don't do that, as a person with what you refer to as complex emotional needs, is at a major, major disadvantage in that conversation, and that's really quite difficult and quite hard sometimes for therapists to live with and tolerate. Anyway, maybe I said too much. Over to you, Carla.
Well, I think Peter very beautifully describes that, the not knowing stance and the other orientation. It does happen that the therapist is struggling to put their own mind aside in order to open themselves up to that extent that Peter describes. And, I mentioned some of these things before. I work a lot with first-year PhD students who are just beginning to learn therapy. And if we begin to mentalize them, they have 50-minute video taped therapy sessions that they then have to bring to supervision, and then these sessions are scrutinized, by the supervisor and the whole supervision class. So in my experience, most of these young therapists have one thing on their mind when they enter the therapy context, and it's not the mind of the adolescent sitting in front of them. It is how they are coming across. Are they staying on model? Are they able to use the skills that they're supposed to be delivering in the treatment? What is their supervisor currently thinking? How's their hair looking? Are they looking fat, sitting like this or like this? So there is a lot of things going through these young therapists' mind. And I think equally for experienced therapists. Experienced therapists have, you described nicely, Maddi, your own life. You have a life outside of the inpatient setting where you work, and so you may be concerned about what's happening that afternoon. So it is very important that in order to open your mind to the mind of the other, that you find a way to track what's happening in your own mind and monitor it and regulate it. And if you begin to be overwhelmed with your own mind, to say that, and to say, can we, I think I missed you there. I think I lost track of what we were talking about. Can we just stop there and go back, because I think I lost you there for a moment. Because it's actually, I think, that dance between self and other, that where the magic of the therapy is going to happen, because it is in the understanding that the therapist doesn't follow everything, that the therapist is also human, that the client can begin to see the mind of the other. So I think that's a very important. You've landed on a very important point about how do we monitor self. We always say that the ruptures that occur because of our self-focus are actually the most important ones. That's when we can, when we repair and we acknowledge and we own the fact that we lost track of the mind of the other. And that's an incredibly important therapeutic moment. So, very important point, difficult to do because you're only human, but it is in that balance between self and other that the magic's going to happen.
Thank you. And I think it's really helpful actually to think about the fact that actually practitioners are human. We have to look after ourselves and then the lives of people that we're working with to the degree that they want us to, or to the degree that it's appropriate, perhaps not look after their life. Perhaps that was the wrong wording, but also being able to say, I got that wrong. I said that wrong. I didn't hear that the way I wanted to, or you wanted me to. It's just so important. And I think for some people as well, this might be the first example of a really positive relationship that some people have had in a very long time. So if we can be honest and transparent and say, oh, I'm really sorry, I didn't quite say that in the way that I wanted to, there's accountability there for that person to go, oh, I do deserve an apology when things go wrong. I do deserve change behaviour, things like that. But I'm going to move us on a little bit now. And another question I have is about discussing things like symptoms, treatment and diagnosis, especially in the early stages. I know that some people are very keen to establish a diagnosis when you're working with them. I was one of them. Some people are the complete opposite. They hate the thought of a diagnosis and a label and things like that, and may just want to focus on a different aspect of the care. And I was wondering what you would say is your approach to discussing kind of the practicalities of care, especially in those early days when you're not quite sure where it's going, but also as your relationship evolves and you start talking about things like the future for this young person after their treatment, or perhaps what their treatment entails. So I suppose the question really is just around topics like diagnosis, treatment, and the pathway into opening up those particular conversations and how that works for you. Carla, would you like to answer that one?
Yes, and so I am very aware that that clinicians and health systems lie on a continuum of how they view this, and patients and clients lie on a continuum of how they view this. I've been quite interested to follow the conversations going on in the UK, because my understanding is, you guys can explain it more to me, that there has been very vocal concerns about the diagnosis of personality disorder, or borderline personality disorder in particular, in the US and other areas where we have been working. We have found that young people and their families are quite eager to receive a diagnosis like you expressed, Maddi, that by the time they're 15 or 16, they have been around the block with mental health services. They have seen clinicians from age 6 or 7. They keep getting all kinds of therapy or even medication that doesn't seem to hit the mark. They read up about things that fit. Adolescents will tell me this. They read about borderline personality disorder and they think that that describes what they're going through, the distress that they're feeling. Yet they cannot find a clinician that can validate that internal experience. So from our perspective, and in the US, I know as well, talking with Andrew Channon, who is one of the sort of leaders in this area in Australia, that they've experienced the same, that there is great value in someone, I don't feel that strongly about borderline specifically, but personality, the idea, the concept of personality functioning. And what we mean with personality functioning is that we are busy building a sense of self. We are busy building a sense of self through adolescence, and adolescence is the key developmental period when this happens, because up until that point, young people don't have abstract thinking capacity that's needed for integrating all of these multiple hypotheses about the self. They are busy, before adolescence, they know that they run fast and that they have blue eyes and that they're kind or whatever it is. They have a self-concept, but they don't have the cognitive capacity to integrate all of these different self-concepts into a coherent sense of self. And that's what personality function is. It is how solid do you feel in the person that you are, and that unit, the person that you are, being a rudder for the decisions that you are making as you go forward. And so it really is about, that's what personality function is. There is not another concept in psychiatry or psychology that captures that idea. And so for me, using the word personality and personality development, scaffolding personality development through relationships, really, in the end, that becomes really an important conversation to have, rather than skirting around the issues. I can go on about how I think that we perpetuate the stigmatization around borderline personality disorder if we don't name it. It's a little bit like Voldemort, we think we can't name it. And then we remain scared of it. It's like any other psychiatric issue or problem. There's nothing special or unique about it in terms of treatability, or in terms of a death sentence, or in terms of a difficult patient. I think we hurt the diagnosis by not being willing to name it. We stigmatize, clinicians continue to stigmatize it, but I know it's a complex issue, and I know that it's quite heated at the moment in the United Kingdom. So I'll stop there and let Peter let Peter answer and give a bit more context.
Thank you, Peter.
Well, I have mixed views about it. I don't think that I substantially agree with what Carla said in terms of the disorder, whatever it is, it's core to an individual. It's core to their functioning. It's core to the way they integrate everything they know about the world and they know about themselves. That I would agree with. Whether it's the term personality disorder is the right one in this context, I have deep doubts. It makes it sound like the person has a disordered personality, and is somehow the person. I've known people with this diagnosis who are nice people, and person with this diagnosis who are not so nice people. You know, and I would say, well, you know, it does carry with it some kind of stigma in terms of, but you're not a nice person and you can't change because it's your personality. So we have to be quite careful about that, I think. But not naming it is not helpful either, because, as Carla says, it adds to the stigmatization. You have an unnameable disorder, you have unnameable problems. And, you know, I tried to, you know, I was a deep believer that you could keep the acronym PD, but just had to call it persistent distress. The person suffers from persistent distress. Didn't catch on, I have to say, it did not catch on. But if we could find, I don't think that complex emotional needs will do either, because to be honest, I have complex emotional needs. And I'm not sure about Carla, but I know that my wife has complex emotional needs as well. And I have yet to see emotional needs that are simple. So, you know, and I would say that was even more stigmatizing. You suffer from simplified emotional needs, simplistic emotional needs, you know, and, you know, so I don't know. But what I do know is that it's an entity, it's something that we need to find a right term for it, and we need to find a term that doesn't hurt. And you started us by talking about language mattering. It matters in this context too.
And I completely agree. I think that we're kind of in a strange middle ground in terms of this diagnosis at the moment of, we've established that there's something here. We've established that quite a few people have it, you know, from time to time, you're going to have someone walk in that door that needs that level of support in that context. But we haven't established the words we want to use, how we want to use them, when we want to use them. And that's giving people who walk through a clinician's door an awful lot of questions they want answered that they can't have answered. And I think, again, in that situation, it's about the transparency to say, you know, well, this is a bit of a tricky situation, but I can give you the best explanation I've got, and you can give me the best explanation you've got, and we can see where they match up. But anyway, I'm going to move us on to our last question now, which is going to be, as I said, I work in participation, so I couldn't do this interview without throwing in a participation question. And I suppose that question is, how does language and communication and the way people receive that impact on their, maybe not ability, but their wanting to participate either in their own care or in a service line or some level of participation? How does communication and language impact and potentially impair participation, do you think? Carla?
You know, I think it impacts, you know, everything that we've been talking about today is really about validating an internal experience, right? And so I think the language and the communication absolutely affects participation, because one feels either validated or invalidated by the way things are communicated. You either feel seen or understood, or unseen and misunderstood. And who would want to participate if you don't feel like you're an equal partner, or if you don't feel like you have a voice that people are willing and interested to listen to? So I think it's critical that that we, you know, I always come back to slowing down. It's just easy to be fast and to make assumptions and to move things along, because we're so product oriented, we're so goal oriented. That's how society works, you know. At least in the US, it's a culture, and so we really just don't slow down enough to create an environment of participation and equal participation. I just want to say, Maddi, I'm so glad to see the lived experience voice that has come louder and louder in our field. I've been just so happy to see that everywhere in all contexts. And the UK has led this effort to a large extent, as well as I think a little bit in Australia and New Zealand. The US is catching on finally. But yeah, I appreciate it, and I think it's critical for us to move forward in the work that we do from all sides.
Thank you, Carla. So Peter, what are your thoughts on that one?
That it's part, to me, participation is part of recovery. Without participation, without a person feeling that they are contributing to something beyond themselves, where they have agency, you're not going to get recovery. As soon as the person is stuck in themselves, and they're not part of a wider system, and that participation is in designing the ward that you were talking to us earlier, or participation in designing their treatment. When I was leading on children and young people's improved access to psychological therapy, one of the major contributions I think we made is to make participation a key and necessary condition of any children and young people service. So to me, any therapy is associated with a slight, but sometimes even bigger, inequality in power. That the therapist somehow is up here and the client, patient is down here. And I think that we know undermines any possibility of improvement. That kind of power asymmetry. You need to bring, if a person is going to benefit, they need to have agency. Any mental disorder involves a sense of a lack of agency, whether it's a lack of agency or not. They feel, so making people feel agented is part of recovery. And I couldn't, what you do, you're doing God's work. You're doing God's work. Not that I believed in that.
Thank you. And that's all the questions that I have for today. So it's been a really helpful and really interesting discussion, certainly from my part. And I really hope that you and those that are going to watch this video will agree. And I wonder if either of you have any final comments for me. Feel free to dive in.
Just thank you for bringing this topic to the forefront. I think stopping for a moment to reflect on the way we communicate, the way that we use language, the way that we can do it a little bit more effectively to create a shared understanding of meaning is worthwhile. And so just thank you for the opportunity to speak with you, Maddi, and with Peter about this important topic.
Thank you.
Yes, I would echo that, and it was particularly pleasant for me to see Carla after some time and hear her views. So thanks, Maddi, for bringing us together as well as bringing us to this topic.
Thank you both. And then I suppose my closing words is just to say thank you again for joining. Thanks to everyone who's going to hopefully watch this video, and if you're able to, please keep an eye on Tale of Three Cities Goes Global this May 2022 for more sessions such as this and more activities. So thank you.
Thank you.
Thanks.